Welcome to the new topic that is on sickle cell anemia. Sickle cell anemia, basically we are going to discuss under hemoglobinopathies. But I mean it's one of the things that has to be discussed in hemolytic anemias, to be honest, but still I'm going to discuss the hemoglobinopathies because it has to be a continuation of thalassemia. If you ask the basic difference between a thalassemia and a sickle cell anemia, the most important difference is going to be on the whether it's a quantitative difference or a qualitative difference. If you ask me about thalassemia, they are quantitative decline in the beta globin synthesis. But if you ask about the sickle cell anemia, it is about the qualitative problems of the beta globin chain. So it's a qualitative change, which means there's going to be some point mutations you're going to discuss that's going to cause some qualitative problems in the hemoglobin. The quality of the hemoglobin and the beta globin chain is going to reduce. That is where the problem in sickle cell anemia is. So what about sickle cell anemia? Like your thalassemia, sickle cell anemia is also an autosomal recessive disease. It's inherited as an autosomal recessive pattern. And the next thing, where it is more common. It's more common in Africans, at the same time who are descendants of the African continent, like your African Americans. Apart from the Africans, your African Americans and your Caribbean population, all these things, all these people are a little bit more prone for inheriting this sickle cell gene or the sickle cell disease associated gene. So why these Africans are particularly prone for the sickle cell disease and sickle cell trait? If you ask me, it has an evolutionary relationship with malaria, especially falciparum malaria. The reason is because sickle cell anemia is thought to give protection, not sickle cell anemia, to be honest, sickle cell trait. That if you ask me about what do you mean by sickle cell trait and sickle cell disease, the answer is very simple. If it's a homozygous problem, then we call it as a sickle cell disease or a sickle cell anemia, sickle cell disease. If it's a heterozygous problem, then we are going to just call it as a sickle cell trait. Sickle cell trait. So for example, how can you write is, you know very well, if the, you have two beta globin genes. If only one beta globin gene is affected with this sickle cell mutation, it is called a heterozygous. If both the beta globin genes are affected by the sickle cell mutation, we are going to call it as homozygous. So which means I can write this is HbSS, the hemoglobin. Why? Because the normal hemoglobin is HbAA. You know that. So this is a normal thing because both the hemoglobin should be of Hb and HbA. If both this normal adult hemoglobin is completely replaced with sickle hemoglobins, because the hemoglobins that has the mutation, sickle mutations, so then we are going to call it a sickle cell disease if both are affected. Suppose if only one is affected, so for example HbAs, which means one gene is normal and the other one is affected by sickle mutation, so we are going to call it as heterozygous. So this sickle cell trait actually is protective for malaria, especially the falciparum malaria. So that is why evolutionary biologists actually think that this sickle cell trait would have evolved as an evolutionary advantage to prevent from deaths due to malaria. You might be asking, why you care about malaria? You don't care about malaria right now. But as a part of the evolution, malaria is one of the mass killers in the world. So it has killed so many African populations because its origin of malaria is thought to be from Africa. So it has killed so many people in Africa in the past, maybe when we didn't have the anti-malarial drugs in the past, in the BC and immediately in the AD eras and all. So that is the reason why evolutionary biologists think that the sickle cell trait could be one of the evolutionary advantages that provide these Africans about the protection from the falciparum malaria. So that is the reason why it could have evolved. And sometimes if it is inherited as a homozygous trait, then you might result in a homozygous problem, then you might in a sickle cell anemia, which might be fatal for the host itself. So anyways, so that is the reason why majority of the sickle cell disease and sickle cell traits you see in the African population or the black population. In India, especially if you ask in the South India, there are certain hilly areas where sickle cell is still common, especially like people from a lot of hilly areas near the Western Ghats, near Kerala and Nilgiris region. At the same time, you can see some sickle cell trait and disease in the hilly areas of northeastern countries also sometimes. So these are the epidemiology which is seen in India. Apart from that, it's very rare to see a sickle cell disease in India as such, in the terrain population. Now coming back to the next thing, what is the problem, actual problem in the sickle cell anemia? It is about the point mutation that happens. Many people do ask me about how a single point mutation can change all these things. Yes, it can change, and how it changes also we are going to discuss. This underscores the importance of a single change in the amino acid sequence that can completely destabilize and change the characteristics of the protein. So that's what we are going to see. Let us see what happens. So what is the point mutation? The point mutation is that in beta 6th position, which means in the beta globin chain, in the 6th position, normally you should have a glutamate. But what happens in sickle hemoglobin? I can write it as sickle hemoglobin, that is sickle cell disease, or you can simply write it as HBSC. So it's a sickle hemoglobin. So what happens in a sickle hemoglobin? So in a sickle hemoglobin, what really happens is it is going to change into valine. So in the beta 6th position, your glutamate is getting transformed to valine. So is that really significant? Yes, we'll see in some time how it is significant. Similarly, if you see in the DNA sequence, this is the amino acid I'm talking about, amino acid sequence of the beta globin chain. So what will happen in the DNA sequence? That is the gene itself. In the sickle gene, at the 6th position, what will happen? Normally you have a sequence called CAG. The CAG is what is going to give rise to glutamate. But there is going to be one point mutation at the adenine site. So it's going to get transformed to something called as CTG. So this is actually coding for valine. So this is the problem. So just a single amino acid change is what's going to create. Actually, the main reason why you get this abnormal hemoglobin and why the property of the hemoglobin itself is changed because of the single amino acid change in the 6th position is because this valine is going to be something called hydrophobic. Whereas this glutamate, you know very well, it is actually hydrophilic. So this change in the property of this amino acid from a hydrophilic glutamate to a hydrophobic valine is what is the main problem they're going to generate in the patient with the sickle cell disease. So this is the importance of the mutation. I'll tell you how it really happens in some time. In subsequent minutes we'll see. But anyway, before knowing that, what is the pathophysiology of sickle cell disease? If you ask me about the pathophysiology of sickle hemoglobin, usually what happens is all the problems happens only in the deoxy state. All the problems will happen only in the deoxy state. In the oxyhemoglobin state, when oxygen is bound, usually the problems doesn't happen usually. Only in the deoxy state, when hemoglobin is devoid of oxygen, at this point only your problems will compound. So what happens in the deoxy state? That is, you can write as TENS form also, because oxyhemoglobin has something called a relaxed configuration, R form, but deoxy state has something called a TENS form. So what happens in deoxy state is the hemoglobin S, that is the sickle hemoglobin that is present in the patient, becomes insoluble. And once the moment it becomes insoluble, which means it's going to precipitate and they're going to polymerize. And once they polymerize and they form a lot of crystals. These crystals are the ones that are going to change the RBC shape completely to sickle shape. So normally the RBC, if you ask me about a biconcave shape, normally RBC is going to be like this, which is going to become a sickle RBC. The problem with the sickle RBC is one more important problem with the sickle RBC is there. What is going to happen is this sickle RBC has something called a less deformability, which means it cannot deform. Why this decreased deformability is again an important reason is because when you have a normal RBC with a biconcave appearance, it can easily squeeze through the microcirculation. It can pass, it can bend, it can flex, it can rotate, it can somehow pass through the small blood vessels, and it can usually don't have any problems at all. But what happens in sickle RBC is these RBCs have reduced deformability because of that, once they go into this microcirculation, they can't pass through the microcirculation, they get stuck in the microcirculation, and once one RBC gets stuck, a lot of subsequent RBCs also get stuck along each other. So they form something called RBC aggregates in the microcirculation because of the sticking of the RBCs to the endothelium. And this RBC aggregates, once they get aggregated, they're going to cause something called a microvascular occlusion. The moment they produce microvascular occlusion, because of the ischemia and hypoxia to the local regions, they are going to cause something called endothelial activation. If you ask me what do you mean by endothelial activation, we are going to see in great detail in the neutrophil section about the innate immunity and all. But before that, endothelial activation means it's going to express a lot of your P-selectin and cell adhesion molecules also. This endothelial activation will not happen alone. Usually this endothelial activation will also be activating the platelets also. So they're going to cause something called platelet activation also. So this platelet also start expressing a lot of P-selectin molecules. Platelet also start expressing the P-selectin molecules. If you ask me where in the endothelial cells this P-selectin is stored, it's in the Weber palette bodies, the same place where your von Willebrand factor is also stored. Similarly, if you ask me where the P-selectin is stored in the platelets, it is stored in somewhere called alpha granules. Alpha granules, these are all the questions. So alpha granules store the P-selectin and they start expressing this P-selectin. Once this P-selectin is expressed in high amounts, they are going to cause more and more RBC aggregation. They are going to cause more and more RBC aggregation. At the same time, they can cause something called local neutrophil adhesion also. Local neutrophil rolling and adhesion to the endothelium. So it's going to cause a messy area, it's going to cause complete microvascular occlusion, and that area might go for severe hypoxia and ischemia, and sometimes even a infarct-like thing also might happen in the local area. So this is the pathophysiology of sickle cell disease in the first place. So if you ask me why you get the sickling and what is the basic problem in this, poor deformability of the cells and why all these things happen. So for that we can see this particular image. So this is something that happens within the RBC and among the beta globin chains. So normally what happens is, let me draw you a separate, then come back to this. If you ask me what happens in the hemoglobin chain, hemoglobin is a nice, you have an alpha and you have a beta chain, and you have two alpha and two beta chains, everyone knows that. So you have a nice alpha and nice beta. This is the first chain and the second chain, nice alpha, nice beta. So this is going to be the same, nice alpha, nice beta. So you're going to have this alpha beta in a different orientation, no problem. So this might be facing outside, this might be facing inside, doesn't matter. Both may be facing outside, doesn't matter at all. So they get, this is how they are. But in a sickle hemoglobin, what really happens is, because of the point mutation in the beta globin gene, your beta globin gene now is going to, this abnormal beta globin gene is going to have a very important compound called valine. I already told you this is hydrophobic. This valine is going to be hydrophobic. You can see that this is the hemoglobin molecule as a whole if you take two alpha and two beta chains, and this is the cytosolic side. So this is the outer cytosolic side because hemoglobin is present in the cytosol. So surrounding the hemoglobin you are going to have the cytoplasm, cytosol. So cytosolic side has a lot of water. Obviously we know that cell is made up, 2/3 of the total body weight is locked in the water. Total body water is locked in the intracellular compartment only. So your cytosol is going to contain a lot of water. So because it's containing a lot of water and valine is hydrophobic, and they don't like it because this beta, now this particular beta chain which is actually seeing the cytosolic side is completely going to dislike this water because they are hydrophobic and they don't like it, and they are going to manually rotate. This chain is going to rotate because they don't want it, so they are going to rotate to the other side and they are going to align themselves something like this. So now this is alpha, beta, beta, alpha, alpha, beta, beta, alpha, alpha, beta, beta, alpha, which means the outer cytosolic side will be facing, the alpha chains only will be facing the cytosolic side, and all the sickle hemoglobins and all the beta chains that contain the sickle mutation are going to be placed in the center. And just turning, of this hemoglobin towards the like orientation will turn like this itself is enough or not. No, they are going to create something called sticky ends. Both the beta globin chains have something called sticky ends, which means they stick with each other as well, which means it's impossible to change the structure of this chain again. So it's a qualitative mutation. The structure of the hemoglobin itself is changed, and that's what is shown here. So you are going to cause your sticky ends. How the sticky ends are? In this you can see very clearly all the alpha are outside, and you can see all the beta chains are inside, facing the inside. And you can also see that they are going to stick with each other. This beta is going to stick with each other by forming something called the sticky ends. How the sticky ends are formed? To form a sticky end, you need, these are protein interactions. These are, the bonding interactions. Even though in the biochemistry textbooks it are given as something like this. They would have given us something like this beta 6 valine acts as a donor site, and your sickle hemoglobin will have something called an acceptor site. So they would have given like donor site is going to, because the configuration change, it's going to just enter into the acceptor site and they're going to get stuck each other. So that is also in a way true, but real thing is you can understand like this. You have two things that is called a donor site and you have something called an acceptor site. The donor is nothing but the thing that that inserts the hemoglobin into that is what we call donor. That is nothing but the beta 6th valine, that is the mutated valine on one side. And the other hemoglobin, that is also sickle hemoglobin only, that is also sickle beta chain only, other chain, beta chain, because you have two beta chains. So the other beta chain in the same hemoglobin molecule, that is also sickle hemoglobin, you are going to have acceptor site in that particular chain. So what is the acceptor site in that? I already mentioned this is the acceptor. So if you ask me what is the acceptor, it is in 85th position you are going to have phenylalanine, and in 88th position you are going to have leucine. So this phenylalanine in the 85th position and this leucine in the 88th position is what is going to act as acceptor sites. So this beta 6 valine is going to get locked into the acceptor positions of the other sickle beta chain, that is in the 85th phenylalanine and the 88th leucine area. Like this you are going to form something similar to this. So you have similarly here, you have the beta 6th valine here, and similarly in this particular beta chain you are going to have the acceptor. So here the same acceptor you are going to have. Similarly you have the beta 6 valine here and you are having acceptor on the other beta chain, the same hemoglobin, and similarly you have the beta 6th valine in this particular beta chain, and in this you are going to have the acceptor. Like this, there is going to be crisscrossed interlinking of the beta 6th valine with the acceptor phenylalanine or leucine at the 85th and 88th position. So these are the acceptor, and this is how you get the sticky ends. This is how they stick with each other. First of all, you have to know why this beta come closer to each other, because of the hydrophobic nature of valine, and why they get stuck with each other, and how they stick with each other. That is because of the donor and the acceptor sites, as I already explained in this particular area. So one more acceptor site is also there. Suppose if they ask you what are the acceptor sites, you are going to confidently tell it is going to be beta 85 phenylalanine and beta 88th position you have something called leucine, and another rare acceptor site is also there, that is beta 70 alanine. This also acts as acceptor site for the valine molecule because they can interact with each other. So these are the acceptor sites which are going to form the sticky surface on the beta globin chains, and they're going to stick with each other. So very important point. Now, so once these hemoglobin molecules get stuck with each other, beta chains get stuck with each other, the hemoglobin molecules are going to become completely insoluble because they cannot free float easily because they are stuck with each other, and they're going to form precipitates and aggregates of hemoglobin molecules. And once they form aggregates of hemoglobin molecules, they are going to form polymers like this, because many hemoglobin molecules also will come and get stuck with each other, and they're going to form something called a polymerization. So what do you mean by a polymer? First of all, before that, you have to know what do you mean by a filament. A filament contains something called two strands. Filament contains something called two strands of this beta globin chain. So this is what we call a filament. So similarly, if you ask what a polymer is, what a sickle polymer is made of something called a central core. You have something called a central core and you have something called a outer sheath. Outer sheath, this is what we call as a polymer. So how many things contribute to the central core? The central core is going to be made of 2 filaments, or otherwise you can even write as 4 strands. Similarly, the outer sheath is going to be made of 5 filaments, or you can also write as something called 10 strands. That is also possible. So central core 2 filaments and outer sheath 5 filaments. Central core 4 strands or outer sheath 10 strands. Like this also you can write. So you have total of 7 filaments or 14 strands. Both are correct. So this is what we are going to call it as this thing. So this is what we are going to take as 1 strand. So similarly, many multiple strands join together to form filaments. Many filaments join together to form a sickle polymer. So you are going to get lot of this polymers of this hemoglobin molecule, sickle hemoglobin aggregates, and they are going to precipitate, and this precipitation of the sickle hemoglobin molecules is the one that is going to cause this characteristic sickle RBC, and this characteristic sickle RBC is what we are going to call it as a drepanocyte in pathological terms. So drepanocytes we have discussed already in the basics of the RBC, red blood cell, in the earlier section itself, but anyways, so this is what we call it drepanocyte. This is the reason why they form sickling and all this problems. So if they sickle, what is the problem, and what are the important points on sickling, and how much of HbS inside the RBC is needed to produce sickling? If they ask you, if the hemoglobin S, amount of hemoglobin S, if it exceeds 40%, then only you can produce sickling. This is one of the important rules on sickling. So then only you can produce sickling. That is the reason why in HbSS, if you ask me, in a homozygous sickle cell disease, 100% will be hemoglobin S only. So since 100% every single molecule is hemoglobin S in this particular area, so you get sickling definitely, because it exceeds that, it's not 40%, it is 60%. Sorry for that. So since it exceeds this 60% mark, so it's going to produce what? Sickling. If you ask me in HbAs, which means it's a sickle cell trait. In sickle cell trait, if you ask me, since one beta globin gene is normal, only one is producing a sickle hemoglobin. So here there will be only approximately 40% of the this thing hemoglobin will be of HbS type. Since it's less than 60%, these patients generally tend to be asymptomatic and they don't have any clinical features. They might have few sickle RBCs in the peripheral smear, but apart from that, they don't have any problem at all, because to produce sickling you need at least minimum of 60% of HbS within the cell, since the sickle cell trait has only approximately 40% of HbS within the cell, so they don't really result in any complications or problems. Similarly, if they ask you second point, your sickling is inversely proportional to the HbF concentration, which means the amount of HbF that you see inside the cell is actually protective for sickling. More the HbF if you see, more protection you will get from RBC to get sickled. That's also very important point, because there is a drug called hydroxyurea which you are going to use as a treatment, which actually increases the HbF levels within the cell, thereby is protective for sickling, and we are going to use the drug for sickle cell anemia. So that is the mechanism there. How HbF is also, in the previous video we discussed, HbF is also protective for thalassemia as well. So similarly, this HbF is also protective for sickling of the RBC. Similarly, third thing, I already told you, sickle trait, the trait HbA, sickle cell trait, is actually protective for falciparum malaria as well. Protective for falciparum malaria especially. How it is protective for falciparum malaria? Again, it's quite simple. I told you sickling will form only in the deoxy state. Will happen only in the deoxy state, and all these problems will happen only in the deoxy state. So what happens is, whenever an RBC is having a falciparum in it, so let us assume this is a falciparum inside the RBC. So this falciparum is going to consume a lot of oxygen, leaving RBC with a little oxygen. So the RBC is actually typically suffering from a low oxygen, which means this falciparum is going to consume all the oxygen, but RBC is going to have a very low amount of oxygen left. Because of that, they enter the deoxy configuration. Once they enter the deoxy state, there is a lot of chance that this RBC may go for sickling. So this RBC which is having this falciparum will definitely go for sickling. Obviously the sickle RBCs will be removed by reticuloendothelial system and macrophages. Removed by reticuloendothelial system in the spleen, and the splenic macrophages will consume all this RBC and the falciparum will be killed. And second thing, the moment the RBCs are sickled, usually one of the important virulence factor of falciparum is expression of one important molecule called Plasmodium falciparum EMP1. It's a membrane protein, PFEMP1. This is the one of the important virulence factors that is responsible for many of the deaths in falciparum. But if once the RBC sickles, the expression of PFEMP1 on the surface will be very much reduced, which means the virulence of the organism will also be reduced in a sickle cell trait. Remember, all these things happens only in a sickle cell trait and not in sickle cell anemia. And sickle cell anemia, it might protect you from malaria, but that's not the important thing, because the patient is going to suffer from a lot of complications and they're going to die, not from malaria, but definitely from sickle cell disease itself. But the sickle cell trait is actually, by the mechanism I've told, it is protective for malaria in the first place. So this is what is happening. So these are the important points that you have to know about the pathophysiology and protective factors for sickle cell anemia. And one more thing I didn't tell you is, sickle cell anemia is, HbF is not only protective for sickling, at the same time co-inheritance of other problems like HPFH, that's called hereditary persistence of fetal hemoglobin. I already told you about this. And alpha thalassemia, these are also protective for sickling. Obviously, in hereditary persistence of fetal hemoglobin, you are going to have a high HbF level. So definitely it is protective for sickling. Similarly, co-inheritance of alpha thalassemia is also considered to be protective for sickling. So after knowing all these problems, we can also discuss on certain clinical features of sickle cell disease. What will be the clinical features of sickle cell disease? I'm not talking about sickle cell trait, because sickle cell trait generally asymptomatic, but even though they can develop complications at certain points in life, but sickle cell disease is what I'm going to talk, classic sickle cell disease. First one is the anemia. The main reason for anemia, typically, it's due to chronic hemolysis. This chronic hemolysis can result in itself, per se, can result in a lot of complications like your gallstones, one of the important complications. Gallstones, obviously, in chronic hemolysis is going to be pigmented stones. At the same time, they're going to be made of bilirubin. That's because of chronic hemolysis. At the same time, this chronic hemolysis can also result in a lot of other complications as well, like your increased erythropoiesis. So your erythropoiesis will be accelerated within the bone marrow. Because of increased erythropoiesis within the bone marrow, they might result in skeletal deformities, as well as they can result in characteristic hair-on-end appearance, or otherwise called as crew-cut appearance. One of the important DDs for crew-cut appearance is sickle cell anemia as well, but not so common, but still possible. That is all due to chronic hemolysis resulting in accelerated erythropoiesis within the bone marrow. At the same time, because of the anemia itself, you might result in pulmonary hypertension. Because of the long-standing anemia itself may cause something called pulmonary hypertension, that is because of hypoxic pulmonary vasoconstriction causing pulmonary hypertension. It can also result in cardiac failure, high output cardiac failure. In the long run, high output cardiac failure. This long-standing anemia is also thought to be one of the main reasons for developing leg ulcers, ischemia, which can develop leg ulcers. So these are some important problems, because leg ulcer is also a very important thing in sickle cell disease. So all these things are thought to be due to the chronic anemia only. So these are some of the problems with anemia. And anemia can happen all of a sudden, and it can, like an acute exacerbation of anemia will happen. So what are the things that worsen the anemia suddenly, all of a sudden? In a patient with sickle cell disease, suddenly, initially hemoglobin is 9 or 10, suddenly it becomes 2 or 3 grams per deciliter in a matter of days. So what could be the reason? So whenever the anemia becomes severe, acute exacerbation of anemia, it might be due to 2 reasons. One is called an aplastic crisis, which can happen in sickle cell disease patient, and second one, you have something called a hemolytic crisis. Suddenly you might have the pathophysiology is very simple. These patients are due to bone marrow suppression, and these patients are due to increased hemolysis, which means one happens in the bone marrow, one happens outside the bone marrow. Hemolysis happens outside the bone marrow, not within the bone marrow. So why the bone marrow suppression happens? This is typically due to parvovirus B19 infection. Typically due to parvovirus B19 infection. That is the reason why they go for aplastic crisis. And in hemolytic crisis, what is the problem? Why they suddenly you have increased hemolysis? Typically, many times the patient will have associated sequestration crisis. Many times the patient will have associated sequestration crisis, typically in the splenic sequestration. But any other thing can provoke the hemolysis, accelerated hemolysis. How will you find out? You know very well. Patient's hemoglobin will have a sudden acute decline. At the same time, if you ask me the reticulocyte count, that will be decreased. Whereas in a hemolytic crisis, if you ask me, the hemoglobin will be reduced and all of a sudden acutely it will happen. At the same time, patient also will have some evidence of sequestration. Evidence of sequestration of RBCs somewhere else in the body, like spleen, manifest by splenomegaly, abdominal pain because of splenomegaly, or it might be due to sequestration in the bone causing bone crisis, or it might result in sequestration into the lungs causing a pneumonia-like picture and infiltrates. All these things are possible. So evidence of sequestration will be there. Plus at the same time, patient will have a hemoglobin decline, which will be acute, which we already discussed, and patient will have a increased reticulocyte count. That is due to counteract the excessive peripheral destruction and compensate for the loss of the RBC molecules in the periphery. So you'll have increased reticulocyte count, which is very important. So increased retic count, decreased retic count. That's a key point here to differentiate between a hemolytic crisis from aplastic crisis. Please do remember that hemolytic crisis typically accompanies a sequestration crisis. Many times when you have a sequestration crisis, you will also have a hemolytic crisis. If they ask you what aplastic crisis, definitely it's most of the time due to parvovirus B19 infection in these patients only. So then next thing, you can think about vaso-occlusion crisis, vaso-occlusive crisis and infection. Vaso-occlusive crisis and infection. So if you ask me vaso-occlusive crisis, you have something called painful crisis. The first division of a vaso-occlusive crisis, you have something called a painful crisis. This painful crisis tends to be the most common of all the crises. So what happens in a painful crisis is very commonly there are 2-3 things which might happen. The first thing is the dactylitis. Dactylitis, that is also referred to as something called hand-foot-mouth syndrome in sickle cell disease patients. Hand and foot syndrome, not mouth, sorry. Hand and foot syndrome. So that is specifically called hand-foot syndrome with regards to sickle cell disease. So what happens in dactylitis? Usually this dactylitis is one of the earliest and the first presentation in sickle cell disease, and many times it happens in the infantile period itself. At the first time, infantile period itself, you will start getting the dactylitis, and usually they cause extremely severe pain, very severe pain, this dactylitis, because of the dactylitis, and which means the reason is because of the sickle RBC is going and occluding the peripheral circulation, because they would get clogged. Once they get clogged, you are going to get microvascular occlusion in this area. Because of that, you will result in a ischemic ulceration or even a gangrene in that area. So once you have a dactylitis, what is going to happen is you might even result in ischemic bone resorption because of the dactylitis. Ischemic bone resorption. What is the problem in ischemic bone resorption? They might result in bones of varying length. For example, one bone may be very short, one bone may be a little bit normal. So bones of varying length is formed. That is because of ischemic bone resorption in the occluded areas. And attacks are completely unpredictable. You don't know when it will happen. And I told you, first site to be affected, even though dactylitis is common in the older children. Suppose if you ask me, this dactylitis is very common in infantile age group only. But if you ask about older children typically have problems with long bones. Long bones, especially your hips, shoulders, vertebra, all these things, these long bones can be affected in the older children. Typically these are the ones that are affected in the older children and adults. And this long bone microvascular occlusion can also result in complete avascular necrosis, especially femur and all. So avascular necrosis can happen in this long bone. So this is happening usually older children and adults. But anyways, so next vaso-occlusive crisis is going to be something called acute chest syndrome. Acute chest syndrome. But in general, this acute chest syndrome has a high mortality and it is improbable to distinguish from a pneumonia. Diagnosing a pneumonia in this case is also feasible because you can't differentiate. You can't differentiate from a pneumonia and acute chest syndrome because both are going to come with infiltrates in the chest X-ray. Both are going to have hypoxemia and both are going to have low saturation. Might have low saturation. Both are going to have hypoxemia. Both are going to have low saturation. And chest X-ray in both these conditions will show typically infiltrates. So in real term, like both will come with shortness of breath. As I told you, in real term, it's extremely differentiated an acute chest syndrome in a patient with sickle cell disease and a pneumonia in the same patient. So that is the reason why many times empirical antibiotics are also given along with routine treatment for sickle cell disease. That is, when they come with acute chest syndrome. The reason is because you can't differentiate a pneumonia from a acute chest syndrome. The most important thing about acute chest syndrome is, apart from presenting with all these features, they are also going to present with reduced hemoglobin and they might have increased reticulocyte count. That is because I told you the sequestration, the vaso-occlusive crisis and the sequestration crisis, here it happens within the lung. That is usually accompanied by hemolytic crisis also. That is the reason why your anemia will be exacerbated at the same time reticulocyte count may be increased in number. So this is what we call acute chest syndrome, and acute chest syndrome per se has a high mortality. Acute chest syndrome per se has a very, very high mortality. Apart from acute chest syndrome, some patients may develop stroke also, like frank stroke. TA also is possible in these patients, again because of microvascular occlusion, and some patients may develop something called splenic sequestration also. Splenic sequestration also. Splenic sequestration usually is associated typically with, since it's again a sequestration crisis, it will be sudden very drop in the hemoglobin plus increase in the reticulocyte count will be seen. At the same time, if you ask me what are the triad of splenic sequestration, it is low hemoglobin, sudden splenomegaly more than what is expected, at the same time if you have an abdominal pain. Abdominal pain, reduced hemoglobin and splenomegaly. So in a patient with a sickle cell disease confirms it's a splenic sequestration. This is one of the important points. So because of recurrent influx within the spleen, because the splenic sequestration itself will result in a lot of recurrent splenic influx. Recurrent splenic influx. Because of that, the spleen may go for something called autosplenectomy. The spleen may be removed by body's own body itself. That's what we refer to as something called autosplenectomy, because the spleen might disappear. Typically, it happens around 5 to 6 years of age. That is the reason why in a patient with sickle cell disease, especially when they are adults or very old children, it's very difficult to look for the splenomegaly. The spleen will be completely normal, or you can't palpate the spleen in clinical examination. That's a very important clue that the patient has gone for autosplenectomy. Initially, the patient will have splenomegaly only, but as the time goes, they'll go for autosplenectomy and the spleen will completely disappear from the abdominal examination. You can't examine the spleen at all. So these are some of the problems. So what are the other issues? Number 3. What are the other issues with sickle cell anemia? Other issues that can happen in sickle cell anemia due to vaso-occlusive crisis, something called renal papillary necrosis. They can cause something called acute ocular occlusion. They can cause something called priapism. They can cause something called a proliferative diabetic retinopathy. Yeah, so these are some of the other problems that can happen along with sickle cell anemia and sickle cell disease. So these are some of the things, and in that in particular note is important about the renal papillary necrosis only, why I will tell you in some time. So, and infection risk, I can tell you this also. What about the infection risk? Because the autosplenectomy, there is very high risk of infection with encapsulated organisms, sepsis with encapsulated organisms. like Haemophilus influenza B, pneumococcus, then meningococcus, all these things are capsulated organisms. So encapsulated organisms risk is extremely high after autosplenectomy. And second thing, usually this infected bone can result in osteomyelitis. Osteomyelitis also. Typically, if you ask me about osteomyelitis, the usual organisms in sickle disease causing osteomyelitis, Salmonella. So this is also possible. So infection risk is also very high in these patients. So these are some of the clinical features. I told you about the, like anemia and what is the reason for anemia, chronic hemolysis part, and what are the problems associated with this chronic hemolysis and the expansion of the marrow because of chronic hemolysis. Then we have discussed on the aplastic crisis versus hemolytic crisis, how to discuss. And hemolytic crisis usually accompanies a sequestration crisis. So what about the different types of crisis? The most important is vaso-occlusive splenic sequestration crisis. Vaso-occlusive crisis we have discussed in detail again. So the most important thing is the dactylitis in infants and children, or even infects of the long bone. Like femur can happen in adults, which can result in avascular necrosis. And the second thing, what you have discussed is on the like various types of syndromes, like acute chest syndrome we have discussed. At the same time, we have also discussed on the splenic sequestration, how it looks like. And we have also seen the other clinical features like renal papillary necrosis, acute ocular occlusion, infection risk, priapism, proliferative retinopathy, all these things we have seen. So these are the summary of the clinical features of sickle cell disease. Do not forget. And what about the clinical features of HbAs? So right now we have talked about HbSS, that is homozygous sickle cell disease. Is there any problem with HbAs? They generally tends to be completely asymptomatic. Sickle cell trait, usually they are asymptomatic in nature. But when they become symptomatic, still, even though I told you they are asymptomatic most of the time, they can develop certain complications. When they can develop complications, especially during pregnancy, or when the patient is traveling for high altitude, going towards a high altitude, or if the patient is undergoing a major surgery. In these conditions, the HbAs, that is the sickle cell trait itself, may show some complications like renal papillary necrosis. Renal papillary necrosis. In general, renal papillary necrosis is not, the common reason is not sickle cell disease. It can happen with diabetes itself. I'll give you the list later on. But anyway, so the renal papillary necrosis due to sickle cell disease may happen due to certain specific lifetimes in the, timelines in the life, like during pregnancy, during high altitude, and during major surgery. Even HbAs, that is a sickle cell trait, also may result in a renal papillary necrosis. Very important point, this one. So if they ask you what is the most common symptom of a sickle trait, I told you the most common manifestation is your renal papillary necrosis. But what will be the most common clinical symptom in a sickle cell trait? Most common clinical problem in a sickle cell trait is hematuria. Again, come on, that is due to renal papillary necrosis. So that's what happened in sickle cell trait. Most common presentation is hematuria, and I told you during what times they're going to develop complications. During these times, during pregnancy, high altitude, and during a major surgery, or immediately after major surgery, they can go for complications like renal papillary necrosis. And how we are going to establish a diagnosis? Before establishing diagnosis, we'll see the clinical features of sickle cell disease. These are the clinical features of sickle cell disease. You can see these are the dactylitis. This is an infant suffering from dactylitis. And if you see this picture is showing a chronic dactylitis, patient with a chronic dactylitis whose bones have got resorbed completely. Because of that, the third digit, if you see, the size itself is decreased in the third digit. That is due to distal bone resorption due to sickle cell disease. This is due to ischemia, microvascular occlusion. Because of continuing dactylitis, the distal bone resorption happens. Because of that, you might result in a shortening of the digit, which I told you already. And this is typically in a sickle cell disease. Definitely, this is an acute chest syndrome. And here, if you ask me about this thing, why I've shown the CT brain, you can see a lot of small infarcts in these areas. So these are microvascular infarcts And many times they might have an asymptomatic nature also, which means even if they have this small infarcts and strokes, they will be completely asymptomatic, or it can be symptomatic as well. So many sickle disease patients will show this kind of small patchy infarcts in the white matter or the gray matter. Very possible. And in this picture we are actually showing the avascular necrosis. You have a large cystic area within the femur and you cannot see the joint line at all. So this is definitely avascular necrosis of femur. Is that no? So this is an avascular necrosis. So that's what happens of femur with a lot of cystic areas. And this is an example of a leg ulcer. Leg ulcer due to chronic hemolysis and chronic anemia. So that is the reason why you get a leg ulcer, which you have discussed already. So these are some of the clinical images that you have to know about the sickle cell disease per se. And how will you diagnose? Diagnosis wise, if you ask me, the most important thing to look for is the RBC indices and the iron indices. The most important RBC indices they will ask you is about the MCV, mean corpuscular volume, and you have something called iron indices. Both tends to be relatively normal. If there is any deficiency, we can correct, but apart from that, the RBC indices and iron indices are usually normal. There won't be any problem at all, which means even, you can categorize the sickle cell disease under normocytic anemias also. But anyways, we don't do that. It's a hemoglobinopathy characteristically. But you can put in a normocytic hemolytic anemia also. That is also possible, where the MC will be completely normal. Very important point. Next thing, what you will see in the peripheral smear? In the peripheral smear, you will see sickled RBCs. Sickle RBCs. Suppose if you want to see the sickling, there is an inducing agent that is called sodium metabisulfite. It's also called a sodium metabisulfite test. So this is one of the tests. The sodium metabisulfite test is the one of the tests that is shown to induce the sickling of the RBCs. That is why, what are the components? It has two components. One is called diethionate and second one is disodium hydrogen phosphate, that is called Na2HPO4. So these are the agents that are present in this sodium metabisulfite compound, and these are the ones that induce sickling. That induce sickling in the peripheral, to identify the sickle RBCs in the drepanocytes in the peripheral smear. So these are some of the important things. So these patients may also show in the peripheral smear, sometimes they may also show this Howell-Jolly bodies in the peripheral smear. That is because of the loss of the spleen in many older children. Once they cross 5 to 6 years, they lose the spleen usually because of autosplenectomy and recurrent splenic infarcts. Because of that, because of splenectomy state, you will get Howell-Jolly bodies. So that is the reason why you might result in getting a Howell-Jolly bodies. And next thing is the HB electrophoresis, finally. Hemoglobin electrophoresis. So what will be the finding in a hemoglobin electrophoresis? You are going to have increased hemoglobin S molecule. That's what you are going to see in any sickle cell disease. So how much the hemoglobin will be, the S will be there, depends on what is the underlying mutation, whether it's homozygous or heterozygous. For example, if you ask me, normal homozygous sickle cell disease, or simply I can call it a sickle cell disease. Then you have heterozygous sickle cell disease, otherwise called a sickle cell trait. Normally, what will be the HbA, what will be the HbS, and what will be the hemoglobin F? Normal amount of HbA is 95 to 98%, and sickle hemoglobin is 0%, and normal is 95 to 98%, and sickle hemoglobin in normal, if you ask me, it's 0%, and HbF, if you ask me, it's approximately less than 2%. This is the hemoglobin F. If you ask me about homozygous, that is sickle cell disease, otherwise simply you can write as HbSS. Double S. In heterozygous sickle cell trait, you can write as HbAs. So how much will be the HbA? HbA in homozygous variant will be usually 0%. You don't have anything. At the same time, in HbS will be 100%, almost, nearly. And rather than writing 100%, you can write 75 to 95%, and HbF will be approximately around 5 to 25%. And if you ask me in a sickle cell trait, what will be the answer? Your HbA will be somewhere around 60%, and HbS will be somewhere around 40%, and HbF will be as usual normal less than 2%. So this is what is going to happen in a sickle cell trait. So these numbers are very important. So you can see, as usual, as I have told you, in a sickle cell disease, that is HbSS homozygous, your amount of HbS, that is your hemoglobin S, is almost in the 75-95%, which means it's more than 60%. So that is the reason why a lot of RBCs are sickled in the protein state itself. But if you see in HbAs, it is only 40%, which means you have not breached the 60% mark, and that is the reason why you don't get this sickle RBCs in heterozygous sickle cell trait. So these are things that are very important. The hemoglobin electrophoresis is actually the confirmatory test for diagnosing the sickle cell disease. So having known about all these things, let's discuss on the treatment of the sickle cell disease. I told you all these things, isn't it? So now let us discuss on the treatment aspect of sickle cell disease. Treatment aspect, if you ask me, first one is the general treatment. General treatment of the sickle cell disease. I mean, treatment in the sense I'm going to talk about sickle cell disease only. I'm not going to talk about sickle cell trait. Be very careful. Trait doesn't need any treatment. Only during certain aspects, I told you, special situation like pregnancy, high altitude, or major surgery, the patient is going to go for some complication. Apart from that, there's no problem. So general treatment is hydroxyurea. Hydroxyurea. The mechanism of action of hydroxyurea is going to increase the HbF. I told you, HbF is going to definitely be protective for sickling. So it doesn't sickle much. So hydroxyurea mechanism is increasing HbF. So what are the indications? At least more than 3 painful crises per year. Painful crisis per year, or at least single sequestration crisis. Sequestration crisis like screening sequestration or acute chest syndrome. All these things are characteristic example of a sequestration crisis. Painful crisis is different. That bone crisis, that's completely different entity. So we are not going to. At least 3 painful crises, that is because of bone problems, or at least a single sequestration crisis. So these are the indication. Any one, or any one, if it's there, then you can start with hydroxyurea. Second thing, other general treatment include folic acid, because folic acid is not specific in any patient with chronic hemolysis. There will be something called a, increased turnover in the bone marrow. That is, erythropoiesis will be accelerated. To support the erythropoiesis, you are giving this folic acid. That is the reason, nothing else. So any chronic hemolysis, folic acid is indicated. Then you have something called L-glutamine powder. This is one of the popular articles in NEJM some 6 years back. So this L-glutamine powder, I mean, this is coming as a brand name called Endari. So this L-glutamine, I mean, this is not needed actually for exams, but anyway, this L-glutamine powder, you can remember, actually this is indicated to decrease the incidence of pain crisis. To prevent pain crisis, this actually is indicated, this L-glutamine powder is indicated right now. So these are some of the treatment aspects for sickle cell disease. Apart from that, you have to treat complications, acute complications. Acute complications, how you are going to treat? Acute complication wise, you have to treat pain and vaso-occlusive crisis. Suddenly, if you have a pain and a vaso-occlusion, so how will you treat this pain and vaso-occlusive crisis? So pain and vaso-occlusive crisis, the first important treatment is hydration. You have to hydrate the patient, because dehydration is one of the risk factors for sickling. So you have to give hydration. You have to give a good analgesia. Typically we prefer NSAIDs plus or minus opioids. This is what we do. So you have to give an adequate analgesia to the patient. Otherwise that itself will increase the panic and pain shock and all will happen. So you have to treat the pain with good analgesia. Transfusions can be done. So when you will do transfusion indication is, suppose if the patient is symptomatic patient plus hemoglobin less than baseline. So what do you mean by that? This is a very tricky line, hemoglobin less than baseline, which means it's not a pure pain crisis only. It's not a pure pain crisis. The patient is also having associated probably underlying reason, underlying understanding about this, why hemoglobin less than baseline becomes an indication, is because patient might have an additional sequestration crisis also, which means unknown. It's not that severe, but probably patient might be having additional sequestration. That's why RBCs are moving into the sequestrated area. That is why the hemoglobin in the peripheral blood is getting drawn. So it's an understanding, that's all. So whenever you have a painful crisis, along with it, if you have a hemoglobin less than the baseline, you can go for transfusion, because that indicates a probable underlying sequestration as well. So this is what you're going to do, transfusion. These are the indications for transfusion. Otherwise, if they ask you whether transfusion is indicated for a routine pain crisis or not, no. In a pure pain crisis with a normal stable hemoglobin, you don't give transfusion. Very important. There is no indication for transfusion. At the same time, there is another drug that is approved. This might be your exam question, that is called crizanlizumab. So this is a drug that is approved. So I told you, in a pain crisis or any vaso-occlusive crisis, the most important pathophysiology is your endothelium expressing excess P-selectin molecule. This P-selectin molecule is the one that serves as a nidus for these RBCs, WBCs and all to get attached to the endothelium. So once these RBCs get attached with this P-selectin molecules, they are going to occlude the local microvascular circulation, and they are going to result in pain and vaso-occlusion. So that is the mechanism. So what if you give a monoclonal antibody against this P-selectin? When you block this P-selectin, monoclonal antibody against P-selectin, that is what we call it as crizanlizumab. So which means it is an anti-P-selectin monoclonal antibody. So which means it prevents the RBCs or WBCs to get adhered with the endothelium and in the microvascular area, so that you don't get this, clogging of these RBCs and microvascular occlusion and hypoxia. So that's why anti-P-selectin antibody. Crizanlizumab is approved specially for this pain and vaso-occlusive crisis. Then you have something called an acute chest crisis. Acute chest syndrome or acute chest crisis is very important. Why? Because this is going to have a very high mortality, as I mentioned previously. Very high mortality if you don't treat. So acute chest syndrome, first thing again, you are going to give IV fluids and oxygen, because oxygen will decrease the sickling as usual, because in deoxy state only you can produce the sickling. Oxygen may prevent sickling. At the same time, hydration is also very important, because dehydration is another factor that increases the sickling. So in acute chest syndrome, what happens is, what are the other treatment you can give is antibiotics. Why you are going to give antibiotics? Because of your inability to differentiate from a pneumonia. Because I told you already, the most important DD for acute chest syndrome is pneumonia. It's literally impossible to differentiate pneumonia from the clinical features what you are seeing in acute chest syndrome. Plus at the same time, you can use something called exchange transfusion also. You can use something called a exchange transfusion. So what you do in, what are the goals in exchange transfusion? Means you completely remove the patient's blood and replace with the fresh blood from a different patient. So that is what we call the exchange transfusion. So what are the goals of exchange transfusion if they ask you? Your what are the indications for exchange transfusion in acute chest crisis? Is if your PaO2 is less than 70 millimeters of mercury, or if the PaO2 declines by more than 10% from the baseline. So these are the indications. So PaO2 less than 70, or if the decline in the PaO2 is at least 10% from the baseline value. So these are the indications. And what are the goals for exchange transfusion? If they ask you, this is to keep the hemoglobin S to less than 30%. Which means when you take this patient's blood out and you replace it with the fresh blood from someone else, you are actually replacing HbS with HbA, normal hemoglobin. So your HbS levels will automatically decrease, because you are removing HbS out of the body and replacing with a normal adult hemoglobin. So that is the reason the goal is to maintain HbS to less than 30%. That's the goal for an exchange transfusion. This is what you're going to do in a patient with a sickle cell disease. Apart from that, lot of supportive care is important. I can write in the general care itself, patient might be needing vaccines. Definitely you have to give, because majority, especially what vaccines, you have to give pneumococcal, you have to give Hib vaccines, you have to give meningococcal vaccines, you also have to give hepatitis B vaccines. So why all these are important? Because pneumococcal, hip and meningococcal are very, very important because many patients have asplenia. That is because of the autosplenectomy happening around 5 to 6 years of age. So you have to vaccinate in prior to prevent the sepsis due to encapsulated organisms. And HBV, because routine number one, at the same time these patients are supposed to receive a lot of transfusion in the future. And again, one of the important preventable disease that can be acquired through transfusion is hepatitis B. So that is the reason we give HBV vaccines also. And apart from that, how will you treat a TA and a stroke? They ask you again a TA and a stroke, you are going to treat with exchange transfusion. Straight away indication. Exchange transfusion. You might need to treat with thrombolysis also. If you ask me stroke, thrombolysis, whether sickle cell disease is a contraindication or no, sickle cell is not a contraindication. Still, you can go ahead with thrombolysis. In the routine treatment of stroke, you can give no problem. So exchange transfusion and all these things are needed. And one more drug, that is a newer drug that has been approved for treatment in sickle cell disease, that is called voxelotor. The clear, concise mechanism of voxelotor is very poorly understood, but it's very well known fact that it is going to decrease HBS polymerization. HBS polymerization within the RBC, which means they reduce the sickling as well. So once they reduce the sickling, they are going to reduce the hemolysis as well. So this is the mechanism of voxelotor. So in summary, treatment-wise, stroke, exchange transfusion, acute chest crisis, supportive management, antibiotics, plus or minus exchange transfusion. If the PaO2 is less than 70 or PaO2 decline is more than 10% from the baseline, TA and stroke straight away, as I told you, it's exchange transfusion only. And many new drugs I have introduced, for example, for pain and vaso-occlusive crisis, generally you treat with hydration analgesia, but additionally you can give a drug called crizanlizumab, which is an anti-PCSK9 antibody, typically which decreases the pain and vaso-occlusive crisis in the future. At the same time, one more thing what you can use is a newer drug I told you, voxelotor, which is also given as a maintenance therapy. So where voxelotor is something that reduces the HBS polymerization. Because of that, reduces the sickling and reduces the hemolysis part also. So remember voxelotor and crizanlizumab for exams, which is very new and can be asked in exams at any time. So be very careful about these two drugs, crizanlizumab and voxelotor in sickle cell. These are the advances. And I also told you about the other general treatment, hydroxyurea and its mechanism. Hydroxyurea, everyone knows it because it's an age-old drug. And indication for hydroxyurea also we have mentioned in detail. So when you will start giving the hydroxyurea in the patient, what are the indications? At least 3 painful crises per year, or after a single sequestration crisis like acute chest syndrome or a splenic sequestration, you can still give hydroxyurea maintenance therapy. All these things are fine. So in sickle cell disease, you are going to use 2 types of transfusion. One is called exchange transfusion and second one is called simple blood transfusion. So what are the indications for exchange transfusion? In exchange transfusion, any sequestration crisis or vaso-occlusive crisis. Sequestration crisis or a vaso-occlusive crisis, but vaso-occlusive crisis purely may not be an indication if it's a pain-related crisis, but typically in sequestration crisis, generally vaso-occlusion also is, used interchangeably with sequestration. So in these conditions, you can use the exchange transfusion. And next thing where you can use is in a priapism. Priapism that is not responding to medical treatment. So initially, a lot of medical therapies are for priapism, which we'll discuss in endocrinology chapter if possible. But apart from that, generally, what priapism that are not responding to medical management, definitely you have to give exchange transfusion in this patient. So these are some of the indications. And third indication, if you ask me, in any patients with complicated surgery that requires general anesthesia for at least more than 30 minutes. This is also very important and very important thing that is asked in exam. So first sequestration crisis, vaso-occlusive crisis, and any major surgery requiring general anesthesia for at least more than 30 minutes, and priapism not respond to medical treatment. All these things are indication for vaso-occlusive crisis. And simple blood transfusion you can use in aplastic crisis and in patients who are having increased risk of stroke. So when you call the patient is having increased risk of stroke in sickle cell disease, if the transcranial Doppler velocity transcranial velocity in the Doppler in carotid is more than 20 centimeter per second. Which means what I'm trying to tell is there is already some sickled RBCs that are occluding the blood flow. I mean, later on it might occlude completely and they might produce a stroke also. So if the transcranial velocity, because of the occlusion, the velocity will increase in the carotid artery. So if the carotid transcranial Doppler, if it's showing more than 20 meters per second, 20 centimeters per second velocity, then you can call it as high risk of stroke. In this condition, you can definitely do a simple blood transfusion. At the same time, to prevent recurrent strokes. And this is a very crucial point to understand. Why? Because if the patient is an acute stroke, you do exchange transfusion, which I told you already, TA, stroke, exchange transfusion, no doubt about that. But if the patient has got a stroke already and you have treated with exchange transfusion, to prevent subsequent stroke as a prophylaxis, at least for 2 years from the previous attack of stroke, you have to give simple blood transfusions as a maintenance. Very important point. Acute stroke, exchange transfusion. Prophylaxis, simple blood transfusions. Very important. That is to prevent recurrent strokes. Or for patients who require simple surgery, if they require general anesthesia for less than 30 minutes, that is what the definition. So if you require GA for less than 30 minutes, it's called simple surgery. In simple surgery, simple blood transfusion is enough. You don't need exchange transfusion. And typically, in patients who are having long-standing osteomyelitis or a long-standing non-healing leg ulcers, non-healing ulcers in the legs, all these things, I told you all these things, maybe why osteomyelitis is long-standing and not healing might be due to anemia itself, and chronic long-standing non-healing ulcers also may be due to anemia itself. To correct that anemia, you can give a simple blood transfusions which might respond. And patients are having pulmonary hypertension, again due to hypoxia, anemia, again correct anemia using simple blood transfusion itself. And patients are having high output cardiac failure. And again, I told you it's due to chronic anemia only. We have discussed already. High output cardiac failure is again due to anemia itself. And because to correct the anemia, you are giving a simple blood transfusion. So these are some of the things that are indications for exchange blood transfusion and simple blood transfusions. To be honest, what are the questions that are asked in exam regarding that is, they will ask all of the following are indications for exchange blood transfusion except, all of the following are indications simple blood transfusion except. Remember, exchange, vaso-occlusive crisis, sequestration crisis, priapism not respond to medical management, any TAA stroke, definitely it's an indication for exchange transfusion. At the same time, if you are having any complicated surgery that requires general anesthesia for more than 30 minutes, sequestration, vaso-occlusion, priapism not respond to medical management, and GA for more than 30 minutes, any surgery, if requires GA more than 30 minutes, you are going to give exchange. Simple, very important is aplastic crisis, minor surgeries where where require general anesthesia for less than 30 minutes. Then prophylaxis of stroke, not acute stroke. Then in patients with high risk of stroke, defined as transcranial Doppler velocity of the carotid more than 20 centimeters per second. Apart from the long-standing osteomyelitis and long-standing chronic non-healing ulcers, then you can use it in pulmonary hypertension. You can also use it in high output cardiac failure. These are some of the indications for exchange versus simple blood transfusion. If they ask you the goal for this exchange transfusion and a simple blood transfusion, it is to maintain hemoglobin in the range of 9 to 10 grams per deciliter. Remember, if you increase the hemoglobin to more than 10 grams per deciliter, that itself might result in hyperviscosity and thrombosis risk is there. So definitely you should not try to elevate hemoglobin more than 10. 10 will be an ideal goal. And you have to maintain the sickle hemoglobin levels to less than 30%. HbS levels should be maintained to less than 30%. That is the goal for any transfusion strategy. And remember, as much as possible, don't give, especially in HbAs, for example, hemoglobin A, usually in sickle cell trait, so this is called a sickle cell trait, avoid simple blood transfusions. Do not give simple blood transfusion in these patients. Why you don't give simple blood transfusions in a sickle cell trait? So if needed, you prefer only a exchange transfusion. Why not a simple blood transfusion in a sickle cell trait? You should not give. The reason is because in sickle cell trait, you don't have anemia. I told you patient will be usually asymptomatic most of the time, only they develop complications at specific timelines in the life. So since they don't develop the problems, and many of the times your hemoglobin in a sickle cell trait, hemoglobin itself will be more than 10 usually. Hemoglobin itself will be more than 10 in majority of the sickle cell trait patients. So that is the reason why you give a simple blood transfusion is to correct the anemia, not for reducing the sickle hemoglobin levels, to be honest. So majority of the times it's to correct the anemia or giving a simple blood transfusion, since the patient themselves don't have anemia. So no need to give any simple blood transfusion in a patient with a sickle cell trait. Even if they develop complications, better try to give an exchange transfusion rather than a simple blood transfusion, because the goal hemoglobin is already more than 10. That is achieved by, that's already achieved in these patients by default, because they are just a trait. They are just a heterozygous patients. They are just carriers. They don't have any homozygous problems at all. So these are some of the indications for simple as well as exchange blood transfusions. But in this same setting, I thought of doing it as a separate one, but just it takes another 3-4 minutes hardly. What are the other abnormal hemoglobins? That also we can discuss. What are the other abnormal hemoglobins in these patients? If you ask me what are the other abnormal hemoglobins in a patient with sickle cell disease, first one is the hemoglobin C. So what will be the mutation in this hemoglobin C, and what will be the clinical features of this hemoglobin C? That's what we're going to see. Mutation, if you ask me, in the beta 6th position of the beta globin chain, same, glutamate is here changed into lysine. That's the problem. So I told you in sickle cell anemia, the glutamate to valine, that's the mutation, but in this hemoglobin C, it is glutamate to lysine. That's the change in the hemoglobin C. What happens if the patient is a heterozygote? In heterozygotes, which means I can write this heterozygotes as HbAc, which means it's a one is HbC, another one is normal. That's what it means. So that's why it's normal. This is hemoglobin C. Only one beta globin gene is affected, or only one chain is affected with this HbC. So this patient usually will be carriers only, and they won't have any anemia. They might have a few target cells, but apart from that, they don't have any problem. Second is homozygous patients, where you have something called HbCC. I can write as HbCC, which means both the genes are affected and both the chains will be having this HbC, hemoglobin type C abnormality. So these patients will have a mild hemolytic anemia plus a little bit of a mild splenomegaly. And the most important factor is not that this patient is having mild splenomegaly or mild hemolytic anemia. It's very important to understand that these patients will have typical this rhomboid shaped crystals in the RBCs. And they will have very much high level of target cells in this patient. These are very, very characteristic actually. These rhomboid crystals and very high level of this target cells. And let us see how these rhomboid crystals will look like in these patients. So what are these rhomboid crystals? So this is an example of, you are seeing a lot of rhomboid crystals here. So this is one typical example where you are seeing this rhomboid crystal, and on the background you can see so much of this bullseye target cells are there. Whatever I'm seeing, I'm underlying. So there's some examples of background full of target cells. You can see so much of target cells you see with the typical this rhomboid shaped crystals inside the RBC as well as outside the RBC can be seen. And so these are characteristic, these rhomboid crystals you are seeing. So this is very classical example. This is HbC homozygous, hemoglobin C homozygous variant. So where you see, as such the clinical features are not severe, but this is typical peripheral smear picture. That rhomboid crystals, very important point in exams, so many times asked, and background full of target cells, very important, please do remember. And second one, if you ask me what are the other hemoglobin molecules you can see, second one is the hemoglobin D. That's what we call as HbD. So what are the problems in HbD is you have something called a beta 121 position, where you have a glutamic acid. Usually you have a glutamic acid which is changing into glutamine. There's a lot of difference, glutamic acid to glutamine in this patient. So this is what we call as HbD, hemoglobin D. Similarly, if you ask me what will happen to heterozygotes, again they will have no anemia, which means there will be no clinical problem at all. And in homozygous HBDD, in these conditions, you will have a mild hemolytic anemia. Again, the clinical features are not severe, mild hemolytic anemia. And finally, third one, you have something called a hemoglobin E. What happens in hemoglobin E is in beta 26th position, you have something called a glutamic acid again, which gets changed to something called a lysine. Once again, so this is the problem in hemoglobin E. In hemoglobin E, what will happen is similarly in heterozygotes, you will have no anemia, and in homozygotes, that is HBEE, you might have a mild microcytic hypochromic anemia. It's not a hemolytic anemia. The patient might have a mild microcytic hypochromic anemia. Very important. Again, they usually don't have a hemolytic anemia. Instead, you will have something called a mild microcytic hypochromic anemia, similar to that of the iron deficiency. So this is what happens in a hemoglobin E. And remember, one more important point about this hemoglobin E is this hemoglobin E is the most common hemoglobin variant in Southeast Asia, which means in countries like India, especially very many times this HBD, HB and all can be seen in more of a like your northwestern parts like Punjab. Those areas, these are very common. So most common HB variant in Southeast Asians. Very important point. Many times asked in exams as well. Most common hemoglobin variant in Southeast Asians is hemoglobin Punjab. Hemoglobin D, hemoglobin E. Very important point. Then what about the compound heterozygotes? We have not discussed about compound heterozygotes. Common heterozygotes. Remember, I told you heterozygotes and homozygotes of HBE, HBC, HBD are not severe. Even a homozygote, even both genes are with HBC, HB or HBD, patient is not going to have that much severe problem, clinical feature. But these compound heterozygotes are very notorious to cause very severe disease itself. Let us see. Common heterozygotes means both the globin genes are showing some mutation, but different mutations. Like one may show sickle, another show beta thalassemia. We discussed already. One may show sickle, another may show hemoglobin C. One hemoglobin may be, one beta globin gene may have D, another beta globin gene may have hemoglobin E. Let us see what will happen in that scenario. Common heterozygotes. Number one, many times they will have very different effects, and you might have any, mild disease. You might have very severe disease. So best example is HPSC. Why this is a common heterozygote? Because one beta globin chain is showing sickle mutation, another beta globin chain is showing hemoglobin C type of mutation, which means both are completely different. Both are showing mutations, but both are completely different mutations. This is what we call common heterozygous. One is normal, only one is showing mutation, is simple heterozygote. Both are showing mutations, same mutation, it's homozygous. Here both are showing mutation, but different mutation, that's why we call it as a compound heterozygotes. What happens in this HBSC common heterozygotes? Actually, it is severe than hemoglobin AS. That is, it's severe than a sickle cell trait, severe than a trait, but little bit milder than sickle cell disease. It's little bit milder than sickle cell disease itself, but definitely it is much more severe than a sickle cell trait itself. And if you compare with sickle cell disease, which means if you compare with sickle cell disease itself, this HBSC actually has some problems happening in relatively more incidence compared to sickle cell disease itself. What are those? Number one is your ocular manifestations, retinal occlusion and all. Ocular manifestations, avascular necrosis, the number of target cells you see in the peripheral smear, thromboembolism, thrombus formation, pulmonary embolism, DVT, thromboembolism in pregnancy, especially thromboembolism in pregnancy, and the spleen size, splenomegaly. All these things are actually relatively more in case of, in comparison with actually homozygous sickle cell disease, these are actually more with hemoglobin SC, this compound heterozygotes, compared to the sickle cell disease. Why actually? And one more thing, usually this HBSC patients, apart from the clinical management, they also have to have, tendency to have very high level of target cells. That is because of the C in it. I already told you some time back, we have seen in HBSC, HBCC, especially in homozygotes, this C means you are having a lot of target cells in the blood. So why you have target cell? That is because the C itself, because hemoglobin C's tendency to create dehydration. Once you create intracellular dehydration within the RBC, if the RBCs go for dehydration, they does produce target cells. So that is the reason even in HbSC, that is your hemoglobin SC, you are getting target cells, lot of target cells. That is because the presence of the HbC component, which means hemoglobin C is going to produce dehydration of the RBCs. That is the reason. So these points are very, very important for exam. What are things that hemoglobin SC is going to have more incidence in comparison with the homozygous HbSS itself, sickle cell disease itself. And second is you can have HbDC. Usually it produces very severe disease, which means when C and D happen together, HbC, D both together, it's a compound heterozygote. It's going to produce a severe disease which can actually mimic a homozygous sickle cell disease. So which means it's not milder, it's severe only. But homozygous HbDD or homozygous HbD or homozygous HbC itself is going to have a mild disease only. We have discussed already. Then you have something called HbE beta 0, that is called, this is a E in one and thalassemia in another, that is a beta thalassemia. So again this is going to produce severe disease and they are going to mimic thal major. Actually they are going to mimic your thal major, thalassemia major. This is very, very complex, isn't it? So one is showing a quantitative mutation, that is quantitative means thalassemia mutation. Another one is showing another gene is another beta globin gene is showing a qualitative mutation like HbE itself. So very complicated. But anyway, this is going to mimic a thalassemia major itself, going to present like a thalassemia major. Number 4, if you ask me, one more thing is there, HbS beta 0, and again this is a typical example of a compound heterozygotes, HbS beta 0, which means one is showing a sickle mutation, another one is showing a thalassemia mutation. One is quantitative, qualitative, very, very complicated, mind-boggling mutations. So in this condition, you are going to see a microcytic RBC, number 1. Why this point is important? Because I told you in pure sickle cell disease, you don't get a microcytic RBC. You will get a normocytic RBC only, even though the RBCs may be sickle shaped, but the volume will be normal. This low MCV is a feature of thalassemia. So you are going to get a microcytic RBC and you will get a splenomegaly. Splenomegaly can happen in both sickle as well as beta 0. So that's not a problem. So you will get a splenomegaly at the same time, but the clinical features will be that of a sickle cell disease. Like it mimics HbS. So it's going to mimic a sickle cell disease. So which means it's going to be a mixture of both these conditions. So clinical features will be like sickle cell disease, but your MC will be low, which is not a feature of sickle cell disease, it's a feature of thalassemia, and splenomegaly, which is an overlapping feature between both sickle cell as well as a thalassemia. So this is what you're going to see in HbS beta 0. So these are some of the important things that you have to know. And apart from that, let us see some of the electrophoresis patterns as well. Before winding up, I'll show you some of the electrophoresis patterns also. So these are some of the electrophoresis patterns that I would like to show. So this is how it looks like. Not electrophoresis typically, these are HPLC patterns. These are high performance liquid chromatography. HPLC patterns that you see might be asked in exam, that's why. High performance liquid chromatography itself is a separate topic which will be discussed thoroughly in biochemistry, how this HPLC, what is solid phase and what is mobile phase. A lot of things are there in that which I'm not going to discuss right now. So let us see what are the base of your HPLC and the hemoglobin. So what is the normal HPLC? If you see, you can see I've just marked, this is a hand marked the areas in the normal HPLC. You can see here, this is area for hemoglobin H, and you can see this area, this is an area for hemoglobin F, that is fetal hemoglobin, and this area is for HbA1c, that peak you are seeing. Normally itself you will see everyone has HbA1c. Next time you go to your HbA1c report you get from the lab and see, they would have given method. In that they would have mentioned HPLC. Actually HbA1c levels in diabetics is also measured through this HPLC only. Go and see in the lab. You will understand once you see the report. Hemoglobin A1c, they would have given method as HPLC, they would have given the value 6% or 7 or 5%, whatever it is. So number 3. Number 4, you can see this huge area is for HbA. In the center, that's a normal adult hemoglobin. And then this is for the minor hemoglobins. This is all for the minor hemoglobin. So for here you have HbE, here you have HbD, here you have HbC, here you have HbS. All these things are generally will be 0%. You won't get any value at all in the normal patient itself. Usually you don't see all this. Generally, normally it's 0 and you don't get any peaks at all. That's why it's in the flat in the baseline. And you will see HbA2 also. This is also something very normally seen, but HbA2 typically it is less than 3.5%, or some books will give you 3% also. Both are correct, but the value of 3.5 you can set it as a cutoff. Anything more than that you call thalassemia trait. That's all. So these are some of the important things. And if you see, this is a case of a beta thalassemia major. What you are seeing in a beta thalassemia major is in 2 to 3 mark. I mean, you can see this is the time actually. If you take the HPLC properly and see, this is the time of elution. This is time. In 2 minutes to 3 minutes mark, normally you see a HbA. But same in 2 to 3 minutes mark, here you are seeing a hemoglobin A very, 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 very less. You don't see hemoglobin A at all. Instead, what you are seeing is in the 1 to 2 minute mark, actually you have to get a HbF and HbA1c. But in the setting of a low HbA, this peak must be HbF only. I mean, it's ridiculous to diagnose an HbA1c of 80% or 90%. So ideally speaking, this is an HbF only. This is a hemoglobin F that is increased. And HbA2 tends to be normal in a thalassemia major, which I have discussed in the previous video itself. Very important point, normal HbA2. So normal HbA2 significantly reduce HbA, increase HbF. All these things typically goes towards a thalassemia major only. And next thing, if you see this is a beta thalassemia major, next thing you can see this is a beta thalassemia minor. So what you are typically seeing in a beta thalassemia minor is your HbA tends to be okay, but not that great, but tends to be okay, HbA, but little bit slight decrease will be there. But if you because the machine is going to give the actual percentage, mild decrease will be there in HbA. And if you see this HbA2, definitely it is more. See, compared to the normal, definitely it is more. The machine is going to give you the value. Definitely A2 will be more than 3.5%. In this, if you take approximately, this is 0, this is 10%. If you take the mark, it's going to be approximately 5+%, maybe 5 to 6% somewhere. Machine will give you the value anyways. So here HbA2 more than 3.5. This is the characteristic diagnostic finding of a thalassemia minor, beta thal minor. Note that in alpha thal minor, your electrophores and all these reports will be normal. So you can see in a sickle cell disease. In sickle cell disease, what you are seeing, this is a homozygous, that is HbSS. What you are seeing here is you are not having the HbA at all, which means HbA is almost 0%, very much reduced HbA. But what you are seeing here is the HbA, sickle hemoglobin, that is hemoglobin S. Typically it happens within the 4 to 5 minutes mark. You can see here in 4 to 5 minutes mark only you get the HbS. So in the 4 to 5 minutes mark you have a peak, that is what we call hemoglobin S, and that is what is the characteristic feature of a sickle cell disease. And you can see the HbF is also increased 1 to 2 minute mark, I mean immediately after the 1 minute mark. So that is HbF. So this is typical of a sickle cell disease. And in sickle cell trait, what you are seeing is your HbA is okay, not bad, your HbA is okay, but still little decreased. If you take the actual percentage, it will be less, but still okay, not a problem. At the same time, you are seeing a peak in the HbS also. So your HbS also is increased, HbA is mildly decreased, not completely absent. So this is typical of sickle cell, and HbF is still normal. I mean, that's a characteristic feature of sickle cell trait, which you have seen in some time back in the table which I have given. So this is typical of a HbAS, sickle cell trait. And what about sickle beta? Like this is something, I mean, very easy to understand. So in sickle beta, what you are seeing is, since both sickle beta means it is HbS beta, HbS and beta, which means one is showing sickle mutation, another is showing beta, which means there is HbA, which means normal hemoglobin is not seen at all, adult hemoglobin is not seen at all. That is the reason why your HbA is significantly reduced. But two things you are seeing, HbS is increased, which you might argue that, like HbS may be increased, why can't it be, you can argue why can't it be sickle cell disease itself, homozygous. Let me come back to that. Second thing, you can see HbF is also increased. HbF is also increased. And again you might argue, why can't it is a sickle cell disease, homozygous sickle cell disease? No, it's not. Why? Because you can see your HbA2 is also increased. It is also increased definitely. Definitely this is more than 5%, surely. So definitely HbA2 is increased. So since HbA2 is increased, I can tell it is thalassemia is also coexisting. Since sickle hemoglobin is also increased, I can tell it is HbS beta. So this is a compound heterozygote. This is sickle beta variant. So this is how you perform in HPLC. This is high performance liquid chromatography. Very important image. Sometimes it might be, this is not very regularly asked in exam, but this gives a lot of edge to you in the exam. Knowing this HPLC pattern, it's very simple to delineate, not a very big deal at all. And many times in exam, they won't just give the value. They don't just give the images, they are going to give the values also. So they will definitely give you the values, because even we predict all these things by seeing the values, not by seeing the image only, because image quality may be different. These are the real-time images that come from HPLC. That's why the image is a little bit like this, but in exam you will get a nice image with the proper value they would have given. Look for the F, S, A2, A values. These are the 4 things you have to look for. Be very careful. So these are some things you have to see. And finally, if you see, this is the last image which I'm going to show. This is a typical image of a hemoglobin electrophoresis. It's a classic image of a hemoglobin electrophoresis. Again, graphical representation, not a real image. So what you are typically seeing, this is a normal. In a normal, you can see a nice HbA, almost 95 to 98%, little HbF less than 2%, and little A2 around less than 3 to 3.5%. Very nice image. So this is a normal. And if you see in a beta thal major, what happens is, as expected, you're not having any HbA at all, because it's a major. Both are mutated. Quantitatively, you don't produce any beta globin chain at all, so you can't produce HbA, which is alpha to beta 2. And definitely your HbF levels are significantly increased up to 60-80%. Usually it will be HbF only, and HbA2 tends to be normal. Very important point. Again, HbA2 normal is a feature of a beta thalassemia major. And what about this beta thalassemia minor, if you ask me? And again, you are seeing a slightly reduced HbA. Slightly reduced HbA. It's not completely absent, but reduced. If you compare with this, a normal, if you take HbA, you compare, it is little reduced. And you are seeing a slightly increased HbF, not much, slight increased HbF, but this and all will not diagnose thalassemia trait. The most important is your HbA2 is increased a little bit more, that's more than 3.5%, characteristic feature of a thalassemia, beta thalassemia minor. Then you are having a HbH disease, which is nothing but 3 gene deletion of alpha genes. 3 alpha gene deletions, this is HbH. Otherwise, they produce something called a hemoglobin H. Beta 4 tetramers. This is what we call the hemoglobin H. So what you are seeing here typically is in the H range. Near the H, you are seeing a band, typical of HbH. That's it. That itself gives you the diagnosis. This is HbH. Apart from the remaining things, doesn't matter. Here the HbH band is what is the most important thing. And next you are seeing delta beta thalassemia and hereditary persistence of fetal hemoglobin. Both are heterozygotes. What will happen in heterozygous delta beta thalassemia and heterozygous hereditary persistence of fetal hemoglobin. So what happens here? So in this condition, what really happens is your HbA is decreased. Definitely in delta beta thalassemia, what happens is the entire delta and beta genes are completely gone, and your hemoglobin F will be definitely increased. There is no doubt about that. So since your hemoglobin F is also increased, your HbA2 levels are variable. If you ask me in heterozygotes, it will be normal. It's heterozygous, only one is mutated. So it will be normal. So your HbF will be increased. How much HbF will be increased? If you see the previous videos, you will tell definitely beta thalassemia video 5 to 30% or 5 to 20%. Different books will give different values, but this value doesn't matter anything. It will be the range of 5 to 20, 30 or 20% usually. So this is what the value you will see. But how will you differentiate between these two? Heterozygous delta beta thalassemia and heterozygous HPFH, that is the hereditary persistence of fetal hemoglobin. Very, very simple. I already told you, do a flow cytometry. Originally, initially they did something called a CLIA or Bedke test. but ideally currently we are going to do a flow cytometry. If you see homogeneous distribution of HbF, that is HPF, I mean hereditary person of fetal hemoglobin. If you see heterocellular distribution of or heterogeneous distribution of HbF in different cells, that is going to be delta beta thalassemia, heterozygous, as simple as that. So the hemoglobin electrophores in this condition will not differentiate the two conditions. Then what about the delta beta thalassemia homozygous variant and HPFH of homozygous variant? In this condition, because for example take a delta beta thalassemia, you have in chromosome number 11 you have initially an epsilon, you have a gamma, then you have a delta, then you have a beta. In delta beta thalassemia you have deleted both this delta and beta, you have only epsilon and gamma. Epsilon will be inactivated in embryonic period cell, only gamma is left, which means since these genes are not at all there and it's a homozygous condition, both genes delta beta are deleted, which means homozygous means both the chromosomes delta and beta are deleted, which means you are not going to get any HbA, you are not going to get any HbA2, and all 100% will be HbF only in this condition. So we have discussed already in the thalassemia section, the last part, how you get, like how you differentiate between a delta beta thalassemia, that is thalassemia homozygous and HPFH of homozygous. Typically speaking, this HPFH, this hereditary person of fetal hemoglobin homozygous, is very rare. But remember, if it's a HPFH homozygous, they tend to be harmless, completely harmless. They won't have any clinical picture at all. Completely they will be normal. They will be having no problem usually. But if it's a delta beta homozygous, they are going to present with a thalassemia intermedia. They are going to have a clinical feature. They are going to present like a thalassemia intermedia. Sir, how is it possible? Why are you joking? In both these conditions, 100% is HbF only. In both these conditions, normal hemoglobin, that is adult hemoglobin, is 0%. Then how you will get one is completely harmless and one you get a thalassemia trait? Thalassemia intermedia. Simple. As simple as that. I told you, again HPFH, this hereditary person of fetal hemoglobin is a pancellular distribution. All the RBs will contain homogeneous equal distribution of HbF. But whereas this is a heterogeneous. Only few RBs will have 100%, everything will be HbF only, but only few RBs will have HbF and few RBs will not have any hemoglobin at all. It's a heterocellular distribution. So since a lot of RBCs are not containing any hemoglobin, they are going to present like quantitative decline in the hemoglobin, that is nothing but a thalassemia. That's it. Since they have a little bit of HbF, they present like intermediate, not like major, not like minor. Very easy to understand. So this is how we are going to differentiate. Based on clinical features itself, we can differentiate. Then comes your sickle cell disease. In sickle cell disease, this is homozygous, which means HBSS. What you are typically seeing is typically 0% of HbA because both are HBSNS, no normal hemoglobin at all. And your sickle band, you are seeing this central is a sickle band here. The sickle band is actually increased, typically in the range of 75 to 95%, as I have told previously. And if you ask me your fetal hemoglobin, the fetal hemoglobin is slightly increased, 5 to 25%, and HbA2 and all will be normal. There is no difference. And if you ask me about sickle cell trait, this is HbAs, which means some normal hemoglobin is still there, adult hemoglobin is still there. So which means here your adult hemoglobin will be decreased, but not normal. At the same time, if you ask me, your fetal hemoglobin, your sickle hemoglobin also will be increased. Presence of sickle hemoglobin with presence of adult hemoglobin also, but adult is decreased, sickle is increased, typical of a heterozygous HbAs, but F, remember, will be almost normal or slightly elevated in this condition. Then what about sickle beta thalassemia, which means here the entity is something HbS beta, that's what you're going to write. So what happens is, since it's a beta 0, it's a 0%, no HbA at all, and you will be having increase in the HbF, at the same time you will be having increase in the HbS also, because S increases HbF, beta means both S, beta, both are there, so which means no normal, so absolutely you are not going to produce, and HbF also is increased. I told you how will you diagnose them, because this looks very similar. HbF increased and HbS increased, it mimics a homozygous sickle cell disease. But how will you differentiate is by this only, HbA2. Here HbA2 also will be increased, but whereas in HbS, your HbA2 will be normal. Very important point. So HbS increased, HbF increased, HbA 0%, HbA2 also increased, means that is sickle beta. If your HbF is increased, HbS is also increased, HbA is 0%, but HbA2 is normal, then it goes towards homozygous sickle cell disease. So what about this HbSC? HbSC means, again, it's a compound heterozygote. HbSC means you have both are mutated, C is also mutated, then you have this HbS, that is also mutated. This is a common heterozygote, which means there is no HbA at all. Adult hemoglobin is not there. That's why it is 0%, no adult hemoglobin. But what you are seeing is, since HbS is there, your sickle hemoglobin will be increased, that is HbS will be positive in this patient. At the same time, HbF also will be increased, characteristic feature of sickle, and you will see a band here near this thing. This is actually HbC. Characteristic is something different. You can actually elude and see in hemoglobin electrophoresis. This might look and confuse you, similar to that of a trait actually, because this HbC band happens in the same area as that of HbA2. I have not written here, but in the same area as that of HbA2, we get the HbC band also. That is the reason why this HbSC is little bit very difficult to differentiate from your what is that, sickle beta thalassemia. So how will you differentiate this HbC from sickle beta? It's very simple. HbSC from sickle beta, typically I told you, this is going to have that lot of target cells in the background. At the same time, the clinical features will be completely different. The clinical features will mimic like sickle cell only, and they tend to have more of problems, isn't it? At the same time, you might see that rhomboid crystals also possible. You might see that rhomboid crystals also. Presence of more target cells, clinical features are completely different, where the patient is going to have retinal, ocular manifestations, avascular necrosis, all these problems. Along with that, like you have all this rhomboid crystals, lot of target cells in the background, typically tends to go towards HbSC disease, and it's very easy. So these are some of the hemoglobin electrophoresis patterns that you have to note down for the exam. So any one may be asked in the exam. So with this, we are concluding the important hemoglobinopathies. See you in the next one.